Welcome to the second webinar of the workshop on innovative data science approaches to assess suicide risk in individuals, populations, and communities, current practices, opportunities, and risks, hosted by the National Academies of Sciences, Engineering, and Medicine's Forum on Mental Health and Substance Use Disorders. I welcome our virtual audience today and those who are viewing the recorded broadcast. My name is Dr. Ben Miller, and I'm the president of Wellbeing Trust, a member of the Forum on Mental Health and Substance Use Disorders, and the co-chair for this planning committee. Thank you for joining us to discuss such an important topic and an exciting one at that. And although this will be a virtual workshop, it is being hosted from a physical location in Washington, D.C., the home of the National Academies and the Forum. For that reason, I would like to acknowledge and offer our deep gratitude and respect to the Nacotchtank, Piscataway people and elders and ancestors, past, present, and future. Everywhere in the United States where our speakers and attendees find themselves at this moment, they are on the lands of Native American tribes and people. So for today, as we discussed in webinar 1, select social media platforms have proactively deployed really sophisticated artificial intelligence and machine learning algorithms to begin to identify individual users who are at high risk for suicide. And in some cases, even activate and take action with local law enforcement or through other resources. And the whole end goal here is to prevent imminent death by suicide. The main goal throughout these workshops is to explore the current scope of activities, benefits, and risks of leveraging these innovative data science techniques to really help inform upstream suicide prevention at the individual and population level. During our first webinar held on April 28th, we heard from experts on the current approaches used by social media and tech companies to determine suicide risk in individuals and populations. Though we didn't have any representatives from these companies, researchers, policymakers, and thought leaders shared information on topics such as mobile-based mental health apps, search engine data, medical and clinical sources like electronic health record data, the importance of community partners, ethical concerns, and social implications. It was truly a tour de force of some of the best thinking out there on how we can identify groups at risk for suicide. If you missed it, I highly encourage you to view the presentations from webinar 1, which are archived on the event page, along with the recording, all for free. Our theme for today's webinar is really about targeting responses to individuals and communities based on their suicide risk stratification, whether that's low, intermediate, or high acute chronic risk for suicide. What do we do with the data we have? What actions do we take? We will take you from identifying population level responses down to the individual level responses today. If you're not sure what that means, thankfully, on our previous webinar, we're going to kick it off today with Dr. Greg Simon, who's going to provide some clarity on the definitions that will be used for today's event. Panel 1 will feature advocates and experts with lived experience moderated by Ms. Colleen Carr. Session 1 features experts who will discuss identifying population-level responses, followed by a short break. Session 2 will begin at 2 o'clock Eastern Standard Time and will focus on identifying individual-level responses. Session 3 will be another moderated discussion by Dr. Patricia Ariane, reflected on the day and getting next steps and actionable items from social media platforms and tech companies to take into consideration. And then my co-chair, Dr. Sean Joe, will adjourn the event at 4 o'clock Eastern Time, with his always insightful synthesis and closing remarks. Throughout the day, please join the live discussion by submitting your questions in the Q&A box for each session. Today's workshop was organized by the planning committee members, who I've mentioned some of them already, but Dr. Ariane, Ms. Carr, Dr. Glenn Coppersmith, Dr. John McCarthy, Dr. Greg Simon, Dr. Aya Zirkli, and was co-chaired by myself and Dr. Joe. The planning committee was supported by NASM staff who are so foundational to getting much of this work done. Ali Andrada, Adrian Formentos, Anisia Wilk, and this workshop is sponsored by the Office of the Assistant Secretary for Health, Indian Health Services, Center for Disease Control and Prevention, and National Institute for Mental Health. Last, this is a webinar 2 of 3 for this workshop. The last installment will cover the unintended consequences, gaps, and opportunities for action on June 30th. We really encourage you to show up for that one. We view these as an organic whole and hope that you'll continue to join us. I think it goes without saying, but there's so much that we need to continue to learn in this space, and our esteemed presenters are really helping us together learn more on that journey. A recording of today's events will be available on the event page roughly 7 to 10 days after this event today. So please refer to the meeting materials for the full itinerary of our program and the bios and CVs of all the presenters. For now, I have the privilege to turn it over to my fellow planning committee member, Dr. Greg Simon, to get us started. Greg.
Thanks very much. By way of orientation, I'll offer a few brief remarks, and especially in terms of the sort of segue or transition from our first webinar to the second. I'm going to continue a theme that I kicked off the first meeting with, which is keeping ourselves focused on the public health or clinical jobs that we hope to do before we evaluate these new data science tools. And we want to make sure that with jobs in the forefront, we decide which tools are appropriate to do those jobs. Next slide, please. So this is a slide I actually showed to kick off our last webinar when it was my scheme about the different jobs that these data science tools might help us with, ranging from the sort of more traditional research or scientific questions about inference or creating generalizable knowledge with an example, moving on to sort of community level detection, detecting hotspots or places or times when there was increased risk of suicide, detecting risk at the individual level, and then finally predicting risk at the individual level. My point is that each of these is a different job, and the point of showing that picture is before we are too mesmerized by the power tool aisle at the home improvement store, we should decide what job we're doing and say what's the simplest and most effective tool we can use for that job. Today, we're going to focus on a couple of specific jobs. Next slide, please. We're going to look at tools for hotspot detection. And I think when we evaluate the potential benefits as well as the risks or potential harms of those tools, these are some of the considerations we need to keep in mind. We need to think about the difference between detection and inference. By that, I mean detection is saying there is an increased risk of self-harm or suicide in this place, in this time. Place could also be defined in the virtual world as well as the physical world. Detection is very specific, while inference is more general. And the mathematical or statistical tools we would use for inference and detection are different. When we're looking for hotspots, we need to have a clear method for distinguishing true from chance findings. As you're all probably familiar, there's a long history of hotspot detection in other areas of health and medicine. We should hope that we can use some of the lessons we've learned, say, from cancer hotspot detection to apply to this field. We need to consider the consequences of false positive errors. What threshold we would set for saying this is a hotspot, there is increased risk would of course depend on what we might do about that. So there is no one answer to the question about false positive errors or statistical significance threshold. The answer is always it depends, but it depends on the action, or it depends on the job we are hoping to do. And then finally, if we would hope to detect hotspots to inform any intervention, we need to know that the timing of detecting increased risk is consistent with the timing of any intervention we might apply. If our goal is inference, it's fine to say that something happened years ago. But if our goal is hotspot detection, we need to know something is happening now and likely may be continuing to happen during a time that we might act in order to reduce risk. Next slide. We're also going to hear about tools for individual level detection or prediction. Some of those in the healthcare sector and some otherwise. When we're evaluating those tools, we need to think very carefully about the consequences of false positive errors. Meaning, if we were to say an individual is currently experiencing a crisis or maybe at high risk for self-harm, what would that prompt us to do? Because the action we might take very much determines the threshold we might use for saying a false positive error rate is acceptable. Conversely, we have to consider the consequences of false negative errors. Would we be offering reassurance, and would that reassurance lead us to not do something that we might otherwise have done? A really critical issue that we'll talk a good bit about today, I think, is the distinction between who might discover the risk, who or what is the entity that would have access to data that would indicate an individual is experiencing a crisis or is at high risk for suicidal behavior, and how that differs from who might act. And what happens when information needs to cross some legal or practical boundary between the knower and the actor. And then once again, when the timing of any detection needs to be consistent with the timing of our intervention. Next slide, please. We're also going to talk about concerns about harms and concerns about risks and rights. We always need to understand that well-intentioned interventions can still cause harm. The example many of us point to, for instance, is welfare checks or armed law enforcement has sometimes led to harm for people who are experiencing a mental health crisis or at risk for self-harm. Sharing risk information across boundaries. When one entity discovers risk and shares information with another, that certainly risks individuals' privacy. And to me, a very important distinction to recognize is that there are autonomy considerations here, which are about rights, not about risks. That people may have autonomy interests in maintaining their privacy, even if there is no action which might put them at risk. And that raises some challenges. When we think about potential risks and harms or ethical or regulatory issues, we need to bear in mind, next slide, please, that while we may tend to focus as researchers on risks or rights or ethical issues related to research, the real issue is about clinical and commercial use of this information. So we need to make sure we keep our eyes focused on the dog and not the tail. And finally, I want to leave you with a dilemma. This is research from a colleague of mine, next slide, at Kaiser Northwest, Bobby Joe Yarborough, asking people with lived experience of mental health conditions and suicidal ideation about what they thought about taking data from external sources. These would be from data aggregators, information about people's credit history or history of arrest or history of eviction or incarceration, asking them, is it okay to use this information to help us identify people at risk of self-harm? 70% of people surveyed said that those kind of data were very or extremely important to identify people at risk, but only 34% of people said use of those data was acceptable. So this is a dilemma about both the power and the acceptability of this kind of information. So with that introduction, I'll now turn it over to our first panel. Look forward to all of your comments during the discussion today. Thanks.